live now.
So very good evening, one and all, and a warm welcome to all who have joined in for the academic feast that is to follow. As you all know, the prevalence of hypothyroidism in India is far much more than that of our Western counterparts. We have a prevalence of approximately 11% compared to our Western brethren, where the prevalence is somewhere between 2.5 to 4.1%. Further challenges to the Indian scenario are that approximately 1/3 of these patients still remain undiagnosed and untreated. So, what should we do right? What are things we need to keep abreast right from diagnosis to management? What are certain caveats across the spectrum of hypothyroidism? To know further, we have a panel of experts from across the country as well as globally. This is the flow of the events, as you all can see. And post the discussion from our esteemed speaker, Professor David Cooper, each center out of the four would be given 5 to 7 minutes for a panel discussion and a one-to-one time with Dr. Cooper, along with the moderators, followed by the vote of thanks and dinner. So without much ado, let's start. I have the honor of introducing each and every one of them. Just to also reiterate, order-wise, when we go from an order perspective, the centers would follow Mumbai, then Delhi, then Bengaluru, and finally Hyderabad. So this would be the order which we would follow in. Each of the delegates have been provided question cards to fill. So as you hear the session and you have any queries, feel free to fill it up so that it can be passed over to the respective regional moderator. Next. So we have the honor of introducing our esteemed international speaker, Professor David Cooper, who's Professor of Medicine at Johns Hopkins University School of Medicine and Professor of International Health at Bloomberg Johns Hopkins Schools of Public Health. We have the honor of felicitating Professor Dr. Cooper virtually. Professor, it's an honor to have you.
Pleasure to be here.
Next, we have the honor of introducing our regional moderator here for the Mumbai team. We are honored to have Dr. Girish Parmar, who is consultant endocrinologist at Nanavati Super Speciality Hospital, Mumbai. I call upon Mr. Abhijit Ganguly to felicitate Dr. Parmar. Next, we also have the honor of introducing Dr. Saket Kant, who's Senior Consultant Endocrinologist at Max Super Speciality Hospital, Delhi, and Senior Consultant Endocrinologist at Action Balaji Medical and Cancer Center, Delhi. We invite Mr. Balram to felicitate Dr. Saket Kant. Next. From the Bengaluru team, it's our honor to introduce Professor Dr. Vagish Iyer, who's Professor at Department of Endocrinology, St. John's Medical College and Hospital. We call upon Mr. Samir Odear from the MacLeod's team to felicitate Dr. Vagish Iyer, sir. Next. Last but not the least, we have the honor of introducing Dr. Beatrice Ann, Additional Professor and Head Department of Endocrinology, Nizam's Institute of Medical Sciences, who is our regional moderator for the Hyderabad team today. I call upon Mr. Ashim Chaudhary to felicitate Dr. Ann. We now hand over the session to our esteemed speaker, Professor Dr. David Cooper, sir. Professor, over to you.
Thank you, and good evening to everyone. It's a pleasure to be able to speak to you, and I'm impressed with how many people are taking an evening on the weekend to come and hear a talk on hypothyroidism. So thank you very much. I've actually been to Mumbai, I've been to Delhi, I've been to Bangalore. Those are all beautiful places, and I hope someday to return. So if I could just have my first slide, maybe I am the one who has to share them now. Can you see my slide?
Yes, sir.
Okay, great. So this is not advancing. I'm not sure.
It's perfect, sir. It's perfect. Maybe you can
Yeah, they're
change.
not, but the slide isn't advancing the way I want it to. Oh, there we go. Wait. Okay. So, yeah, as you heard, I'm connected with Johns Hopkins University School of Medicine in Baltimore, Maryland. This is just a picture of the original Johns Hopkins Hospital that was built about 100 years ago. For those of you who don't know where Baltimore, Maryland is, I just put a map of the U.S. Baltimore is just about 40 miles north of Washington, D.C. So this is what we're going to be talking about this evening for the next 45 minutes or so. Talk about hypothyroidism and distinguish between overt and subclinical hypothyroidism. Not really talk much about the causes because you know that. More about the treatment of hypothyroidism. Mention hypothyroidism in pregnancy. And then we'll end the discussion talking about mild or subclinical hypothyroidism. So everybody, I think, knows what hypothyroidism is. It's a deficiency of thyroid hormone. And 99+% of all hypothyroidism is due to the thyroid not functioning properly. There is, of course, secondary or central hypothyroidism due to pituitary or hypothalamic disease, but this is incredibly rare. And, maybe in your lifetime, you'll see 10 cases of this. The vast majority is all due to thyroid failure. And of all those, the vast majority is due to autoimmune or Hashimoto's thyroiditis. Yes, people can be born without a thyroid. There can be congenital enzyme deficiencies and that sort of thing. But most people who have hypothyroidism have it as an acquired defect due to autoimmune disease. Post-ablative hypothyroidism, obviously we see in post-surgical after cancer surgery or Graves' disease, toxic multinodular goiters. And then there's a host of drugs that can cause hypothyroidism, as I'm sure you know. And among the most prominent are lithium, amiodarone, and then the new checkpoint inhibitors that are used to treat certain cancers that can induce thyroiditis very quickly. So in terms of the issues, the goals, obviously, of treating somebody are to reverse whatever symptoms they have that are due to hypothyroidism, prevent any consequences of long-term thyroid hormone deficiency, let's say coronary artery disease or cognitive impairment. But on the other hand, there's always the danger of overtreatment with iatrogenic thyrotoxicosis, which can have adverse effects on the cardiovascular system in terms of atrial fibrillation, bone loss. And now we recognize also that mild hyperthyroidism can also cause a cognitive dysfunction in elderly people. And of course, there's always the risk of undertreatment as well. And in fact, both of these dangers are well documented in a number of studies. I'm sure there are more than this even that are published, but you can see here that these are 5 studies just showing of people taking levothyroxine to treat hypothyroidism, almost half of them don't have a normal TSH level. Some are overtreated, so their TSH levels are low. Some are undertreated, so their TSH levels are high. And particularly alarming is this study all the way over on the right, where this is only people over the age of 65, 36% of whom were being overtreated with levothyroxine. So this is a problem that needs to be addressed in each of your practices, and it's very difficult to do this because patients obviously don't necessarily take the medicine the way they're supposed to, but it's important to obviously continue to monitor this for the duration of a person's life if they're taking levothyroxine, and most people are taking it for their entire lives. Now, there are a number of different preparations of thyroid medications. The main medicine that we use, obviously, is levothyroxine in tablet form. Some countries have gel caps and liquids. T3 is also available, but we don't use this very much. There's been a movement to try combination therapy of T4 plus T3 in certain situations, and I'll mention that later. And then, at least in our country, there's desiccated thyroid. I'm not sure if it's available in India. This is desiccated porcine thyroid or beef thyroid, but this is probably obsolete. Some patients in our country do take this, but it's not well standardized, and the amounts of thyroid hormones that are present in these preparations is not well characterized, so we don't recommend this. So here's our first patient. She is a 70-year-old woman with fatigue. She sees her primary care doctor and is found to have a TSH of 23 and a low free T4 level. Other than her fatigue, she really doesn't have much in the way of symptoms. This is pretty typical of elderly people who are hypothyroid. And by the way, hyperthyroid too, often they don't have a lot of symptoms. Why this is, we do not know, but it's very typical. She has lots of other health issues, including osteoporosis, rheumatoid arthritis, diabetes, heart failure, COPD, etc. So what factors enter into the final dose for levothyroxine that this patient will take to normalize her thyroid function? There are obviously a whole list of things you could consider: her age, her weight, how hypothyroid she is, other illnesses, other medicines she's taking. And then also, not just the final dose, but how should she be started on her medicine? Should she just take the full replacement dose right off the bat, or should you use the start low, go slow regimen? So let's just talk a little bit about the medication that we're going to use in this patient. Obviously, the tablets are not 100% absorbed, but they're pretty well absorbed in most healthy young people, maybe up to 70 or 80%. But the absorption is lower in older people. And it's important to recognize that the tablets need to be dissolved in the stomach with gastric acid. So if people have atrophic gastritis or they're on proton pump inhibitors, they will not absorb the medication completely. And this is, in our country, a role for the liquid preparation in people that have absorption problems. But if you increase the dose, often this can be overcome with tablets as well. The medication, once it's dissolved, is absorbed along the small bowel. It has a long half-life, and the half-life is longer in the elderly. This is really important that the metabolism of levothyroxine is prolonged in older people. And of course, you all know that T4 is really not the active thyroid hormone. It has to be converted to T3 in the peripheral tissues or in cells. And there's this argument that some people might not efficiently convert T4 into T3, and this would be the rationale for using combination therapy, which we'll talk about in a few minutes. So the normal daily production rate of levothyroxine for the average person is about 80 to 100 or 125 micrograms a day. And given the absorption of 60 to 80%, this leads to the average dose for the average person of about 100, 125, 150 micrograms a day, something like that. And based on weight, this is a sort of a crude target dose that you can sort of estimate based on the patient's body weight, but this is very, very crude. And it's important to recognize that in obesity, this does not work. You will end up over-treating people. And in obese patients, the dose is really related to the lean body mass, not the body weight. And also in the elderly, this formula does not work because of the slower T4 metabolism in elderly people. And in fact, the body weight dose is 1.3 micrograms per kilogram per day in older people. Because its half-life is 1 week, you only have to take the pill once a day. That's good. It really doesn't matter when a person takes the medicine. Some people prefer to take it at bedtime because that way they can get up and have their breakfast and their coffee and move on and not have to wait to take their breakfast or that sort of thing after they take their medicine. It really should be taken on an empty stomach. Coffee and espresso have been shown to impair absorption. So it really should be taken on an empty stomach with water. Some people say, well, if I want to take it at bedtime, how long do I have to wait till after I eat dinner? And in general, the stomach is empty after about 120 minutes or so after you eat. Because the half-life is so low, missed doses can be made up later that week. If the patient remembers they didn't take Tuesday's dose, they can take 2 on Wednesday. And then in some special circumstances where patients just cannot be trusted to take their medicine, they theoretically could take it all 7 pills once a week, or maybe 4 pills one day and 3 pills, a few days later, something like that. This would not be, the optimal thing to do, but in special circumstances, this could be done. So what influences the ultimate dose in the average person? Obviously the TSH. The higher the TSH, the more medicine they need. But there are other factors that influence the final dose, and we'll talk about that in just a second. But this is just a slide looking at the baseline TSH for the patient and then the ultimate replacement dose of levothyroxine. I know it seems impossible that this line could be so beautiful with those dots, but this is the paper. And you can see that, the higher the TSH, the more ultimately the patient needs to replace and normalize their thyroid function. Age is really important. And as I mentioned earlier, the dose goes down as people get older because people who are elderly metabolize levothyroxine more slowly. But at the same time, they also absorb the medicine less well. So in elderly people, it's a challenge because, again, they metabolize it more slowly, but maybe they don't absorb it as much either. So you're playing those two factors against one another. Also, there are lots of different drugs that have effects on T4 absorption and treatment. And this is particularly pertinent in elderly people because they're the ones that have polypharmacy. And I'm not going to read this whole slide, but just if you look at the top, the ones that block absorption are really the most important. And you know that calcium and iron certainly do this. Large doses of soy can do this, orlistat. And then I'm not going to mention the other drugs except to say that proton pump inhibitors, by decreasing stomach acid, also have effects on thyroid hormone absorption and often lead to the need to increase the dose. And I'll just mention drugs that increase TBG levels over here. I don't know if you can see my pointer, but estrogen is really important, and we'll talk about that in a minute. But if women are on estrogen or on birth control pills, that often leads to the need to increase the dose. So in terms of general principles, people taking drugs and supplements should really try to separate these by 4 hours. I mean, not every drug interferes with the absorption, but some do, and you have to know which ones do, which ones don't. And then importantly, if the person stops taking that drug or supplement and you have increased the levothyroxine dose to accommodate that, then when they stop taking it, they may end up being on too much medicine, and you have to think about cutting back and checking the TSH and possibly readjusting the dose. Also, I'm not sure whether people in India use biotin. Women here in America use it as a supplement for nail health and hair growth. And some commercial assays for TSH and free T4 are interfered with by biotin and cause a falsely low TSH. And after they take their dose, things just don't change that much. And so it really doesn't matter. Obviously, there's a target TSH in general. Most people have a TSH that's less than 3, and so the target would be between 0.5 and 2.5 to 3. But this is controversial in elderly people because, as you may know, the TSH normal range differs for elderly people compared to younger people. And this is just one slide showing this. This is a distribution of TSH levels in people in their 20s, 50s, and 80s. And you can see that the distribution for TSH is shifted to the right as you get older. And so for an 80-year-old, the upper limit of normal could be as high as 7.5, for example. For a 60-year-old, it could be up to 4. Now, there are no age standardized reference ranges for TSH assays in my country, and I bet there aren't any in your country either. We do have pregnancy trimester-specific reference ranges that labs have, but not age-adjusted. So you have to keep this in mind. These are healthy octogenarians. These are not people with underlying autoimmune thyroid disease. These people do not have a family history of thyroid disease. They do not have antibodies. They do not have a goiter. These are just normal, healthy, older people. And so when members of the ATA or others are asked, well, what is the target TSH for people with hypothyroidism? You can see that some experts think that even people in their 60s, 70s, and 80s should have a target TSH of between 2 and 4, and maybe even above 4 to 6, for example, in people in their 80s and 90s. So in terms of how to start the medication, I think most of us agree that if the person's healthy and under age 50, no history of heart disease, you can just start the person on the full replacement dose. These are people with overt hypothyroidism. But for older people or people with underlying cardiovascular disease, it's probably more prudent to start with a lower dose, 50 or 25 micrograms a day even, and then increase the dose based on serum TSH levels. And so if the TSH is above 5 after being on levothyroxine for 6 or 8 weeks, then you'd want to increase the dose probably by about 25 micrograms. If the TSH is within the range that you're happy, you can just continue it and the dose and check it again maybe in 6 months. And then if everything's fine, just once a year is adequate. And if the TSH is low, then obviously you're going to decrease the dose by 12.5 or 25 micrograms a day and repeat in 6 to 8 weeks. And of course, you know that all you have to do is tell the person, for example, if they're taking 125 micrograms a day, they can just take 125 micrograms 6 days a week and lower the dose. And that would be the same as changing it by 12 or 25 micrograms a day. So if the dose needs to be decreased, we typically see this as people get older. So a dose that's fine for someone in their 30s, 40s, 50s may not be the right dose when they get to be in their 70s and 80s because of decreased metabolism. So the dose may need to be decreased, even though the person's been on that dose for decades. If a person loses 10 or 15% of their body weight, that could change the dose. Other medicines adding or taking away, we mentioned that. And then the dose may need to be increased in a variety of conditions. And I just want to mention pregnancy here, and I'll talk about it in a minute. People starting oral contraceptives because of estrogen increasing TBG levels often need to have their dose increased. And then malabsorption, drugs that decrease absorption. We've talked about all of these. And I'll also just mention amiodarone, which blocks T4 to T3 conversion, not only peripherally, but in the pituitary gland. So the TSH often goes up when people are on levothyroxine and start amiodarone therapy. This is that same slide that I showed you, just again to remind you how easy it is for people to end up on too much or too little medication, no matter what good, how much we try. These articles are all just from, standard, typical clinics in the United States. And the three areas that we are concerned about when people are on excessive levothyroxine is the skeleton, the heart, and the brain. So this is just one of many studies looking at fractures. These are femoral fractures in people taking levothyroxine, 17,684 people. And you can see that the risk of fracture is greater in people who have a completely suppressed TSH compared to people who have a low, normal, or high serum TSH. And here is a study looking at atrial fibrillation incidence in people who are on levothyroxine after a thyroidectomy for thyroid cancer. And you can see, again, a higher risk of atrial fibrillation in people with thyroid cancer only because their TSH is low, unnecessarily in many cases. And then this is a recent study looking at older people, people over the age of 65, who have either endogenous or exogenous thyrotoxicosis. So the exogenous is in blue. You can see that the prevalence of thyrotoxicosis is greater as people get older. That is to say, they're just given too much medicine and they end up having hyperthyroidism unnecessarily. And then if you look at the right-hand side, this is cognitive impairment in people that have thyrotoxicosis, either endogenous or exogenous. And the blue line is the normal people who don't have thyroid disease, and then this is the orange line in people who have thyroid disease. So there's an increased risk of cognitive impairment from iatrogenic or endogenous thyrotoxicosis. Let's just talk about T3 just for a moment. This is a patient who had a thyroidectomy for thyroid cancer 3 years ago. And even though her thyroid function tests are completely normal, she has fatigue, cold intolerance, and mental fogginess. And she's read online that adding T3 to her regimen might help her with her symptoms. And she asks you to check her T3 level. And then the question is, should a combination of T4 and T3 be considered in this patient? So, as you know, T3 is the biologically active thyroid hormone. And even though T4 generates T3 in peripheral tissues, you can't really guarantee that every single tissue in the body has a normal T3 level because we don't really know how to monitor that. And it may be that some people don't convert T4 into T3 efficiently. And so this used to be anathema. People thought anybody prescribing this was, crazy. But this is actually gaining in popularity, as you probably know. But there have been 12 randomized placebo-controlled trials showing that it doesn't do anything. So how could we continue to talk about this when all these trials say that it's not superior to T4 monotherapy? And the reason people keep talking about this, despite all this evidence, is that when people, the patients in these trials are asked, which period of time did you prefer? Forget the questionnaires and the symptom scores, the mood scores. Which period of time were you feeling the best? More people prefer the time of during the study that they were taking the combination of T4 plus T3 versus the time they were taking T4 alone. So this might only apply to people who have specific enzyme or genetic defects in T4 to T3 conversion or transporters into cells. So there are genetic polymorphisms where people are less efficient at converting T4 into T3. So T4 monotherapy is the standard, but I think in selected patients, a trial of combination T4, T3 might be considered, at least for a few months to see if it makes any difference in how the patient is feeling. And the way you can do this really easily is that since T3 metabolically is about 3 times as potent as T4, if the patient's TSH is normal, you could just add 5 micrograms twice a day to their regimen. That's roughly equivalent of adding about 15 or 20 micrograms of T4 to the regimen. It has to be taken twice a day because of its short half-life. If the patient's TSH is already low, you could substitute 5 of T3 twice a day for 25 micrograms of T4. So if they're on, let's say, 125 micrograms a day of T4, you can reduce it to 100 micrograms a day and add the T3. Then you would want to check thyroid function tests. And if you want to check the T3 level to be sure it's not elevated, you'd have to measure it 3 to 4 hours after they take their dose, not early in the morning when the levels will be back to baseline, because, again, the half-life is very short. Now, there are potential problems with taking T3, especially with higher doses, cardiac arrhythmias, decreased bone density in postmenopausal women. The degree of risk is not known. Also, this has not really been tried in elderly people or people with heart disease. I would really recommend not doing this in people that are over the age of 60 or 65. And also, there's no role for this in pregnant women since T3 does not get into the fetal brain the way T4 does. And obviously, we would not want to do this in children either. Okay, let's talk a little bit about hypothyroidism in pregnancy. Here is a 24-year-old woman with longstanding hypothyroidism. She comes to see you because she's interested in starting a family. She's been taking 100 micrograms of levothyroxine a day for many years. You check her TSH, it's normal, it's 2.3. What advice would you give her about her thyroid medication if she becomes pregnant? So this is just a slide looking at TSH levels in women who are pregnant. And the scary thing is that in this study from the UK, 62% of women had a TSH that was greater than 2.5, and about 30 or 35% of women had TSH levels that were greater than 4.5. And I've shown you with these arrows here that there's a risk of miscarriage If the TSH was greater than 4.5 or greater than 10, certainly, and the risk ratios are here. So the risk was 1.8 in TSH levels greater than 4 to 10, and then a risk of fourfold if the TSH was greater than 10. So what this means is that many women who become pregnant don't have pre-pregnancy planning to make sure their TSH is normal before they try to get pregnant. So the thing is that when women are pregnant, the dose goes up. And that's because some of the thyroid hormone crosses the placenta and is necessary for fetal brain development and growth and development. Also, TBG levels go up from estrogen, as you know. And also, there may be increased clearance. We don't really know the full mechanism of why this happens, but it happens in most pregnant women. And the degree of dose increment depends on the underlying thyroid disease. So the dose might have to go up by 25% or 30 or 40, even double in some women. In breastfeeding, the dose really doesn't change. So there should be pre-pregnancy counseling, and the TSH should be optimized so it's between 0.5 and 3 before the woman tries to get pregnant. And as soon as pregnancy testing is positive, they should check their TSH. And then the dose needs to be increased in most people. And again, it depends on what their underlying thyroid problem is. If they've had an ablation or a thyroidectomy, it usually goes up by 40 or 50%. In people that have some thyroid still but are hypothyroid, it may have to go up a little less. And then there are other instances where the dose doesn't change. And I'll just mention patients with thyroid cancer, let's say, whose TSH has been maintained in the subnormal range to avoid, recurrence of thyroid cancer. Maybe the dose in that patient might not need to be changed at all. And this is a study just looking at serum TSH levels in women who could become pregnant and the need to increase the dose. And you can see in women where the TSH was less than 1.2 when they got pregnant, only 17% of them needed to have their dose increased, as opposed to 50% of women who had TSH levels that were between 1.2 and 2.4. This is just a slide looking at TSH levels across the trimesters. The solid line are just normal women, not on any medicine at all. And then the dashed line are pregnant women whose dose of levothyroxine was increased by 2 or 3 pills a week. And you can see by doing that, these women basically had normal TSH levels throughout gestation. So if a woman is on levothyroxine, you need to check the TSH every month or so for the first 20 weeks, because that's when these changes occur. And if there is a dose adjustment, you should probably check the TSH every 4 weeks minimum. Women need to be told to separate the ingestion of their pill from iron, which sometimes is present in prenatal vitamins, or iron supplements, soy milk or calcium supplements. You should avoid this combination therapy, as I mentioned before, in anyone who's pregnant, because the T3 doesn't get into the fetal brain. And then after delivery, reduce the levothyroxine back to the pre-pregnancy dose and recheck the TSH 6 weeks postpartum. And I'll also just make a comment here about iodine. You should be sure that women who are taking prenatal vitamins are taking vitamins that have iodine in them. Many prenatal vitamins do not, in my country at least. And you want to make sure the woman is getting an adequate amount of iodine in her diet for the fetal thyroid health. So what advice should we give our patient if she gets pregnant? And the answer is check the TSH when she finds out she's pregnant, and then increase her dose by 2 pills a week, and then check the TSH again in 4 weeks. I want to close by talking about subclinical hypothyroidism. So here's a woman referred to you because her TSH is 6 with a normal free T4. She's feeling fine, but of course, as most 70-year-old people do, she has mild chronic fatigue. Thyroid is normal on physical exam. Repeat free T4 is normal. Her TSH is 5.8. You check anti-TPO antibodies, and they are weakly positive. And so the question is, should this lady be started on levothyroxine therapy? So this is a case of subclinical hypothyroidism. As you know, this is characterized by normal levels of T4 and T3, but elevated TSH. 80% of these people have TSH levels that are less than 10. People have graded this into grade 1, which is milder, and then grade 2 is where a TSH is greater than 10. Many, but not all people have positive antibodies. And some people would just call this mild hypothyroidism, and that's fine. It's pretty common. The prevalence goes up to 15% in some populations. But, obviously the prevalence here depends on the upper limit of the reference range that you are using. So that gets back to this idea of what is a normal TSH. And I've already gone through this with you, but I think it's important just to remember that age leads to an increase in the TSH, even in normal people. So a TSH of, 6 or 7 in an 80-year-old isn't necessarily subclinical hypothyroidism. That just could be a normal TSH for that person, especially if their thyroid exam is normal and their anti-TPO antibody titers are normal. So what are the reasons that we might even care about this? And the reasons are listed here. There may be altered cardiac function. There may be dyslipidemia leading to cardiovascular disease. The person might have potentially symptoms, altered functional status, cognitive function. Maybe it's causing the person's mood to be low. And then there's always this worry that even though it's okay now and kind of mild, maybe over the years it'll progress to overt hypothyroidism. So why not treat now so you don't have to worry about it anymore? So let's just talk about each one of these three factors. So there are a number of epidemiologic studies that show that as people's TSH gets higher and higher and higher, the risks of coronary disease events and mortality and heart failure go up significantly. But you'll see that most of this, abnormalities that are found are when TSH levels are greater than 10. And in that range of 7.0 to 9.9, yes, there is some risk potentially in some of these studies, but not in all of these studies. And so that's where all the controversy is. Where is the line drawn in terms of the TSH where you would start to worry about cardiovascular disease? And I'll just point out, though, that as people get older, then the risk of mortality goes down as your TSH goes up. I know this sounds contrary to what you might think and contrary to what I showed you on this slide, but these are not elderly people. These are all comers, and most of these people are middle-aged and not elderly. So if you look here, as your TSH goes up, we're looking at mortality here on the right, on the y-axis, and it goes down. So the higher your TSH, the healthier you are. I'll say it again. The higher your TSH, the more likely it is that you will live longer. Why this is, we do not know, but this has been shown in many, many studies. Now, this is not a randomized trial, but I think it's a very important study from the UK, where they analyzed thousands of patients in the general practitioner database and found that in people with subclinical hypothyroidism on the left, who are age 40 to 70, the incidence of ischemic heart disease events on the y-axis was lower when people were given levothyroxine for their subclinical hypothyroidism, and that was statistically significant. On the other hand, in people over age 70 who either were or were not treated, there was no difference. And it looks like T4 treatment makes things worse, but that was not statistically significant. So maybe there is an age-specific aspect to this, where people who are younger might benefit and people that are older might not. And this has led to this kind of slide that I have made, where it looks like maybe the risk is higher in people that are in their 50s and 60s, and then it goes down to baseline, and then maybe even as you get older, people in their 80s and 90s, as I said, they even have a lower mortality, even though they have subclinical hypothyroidism. What about symptoms or other altered functional status, that sort of thing? This is a slide. There are many slides looking at symptoms in people with hypothyroidism, both overt and subclinical. And you can see here that although overt hypothyroidism may be associated with more symptoms, the symptoms really don't seem to be very different between people that are euthyroid and people who have subclinical hypothyroidism. This is a study looking at walking speed, which is used by geriatricians as a measure of overall function. And the black is rapid. In other words, the patients are told to walk as fast as you can. And then the white is the usual walking speed. And these are people in their 70s. And at the bottom, these different groups are different TSH levels. And you can see that, contrary to what you might think, the higher your TSH, the faster you walk. I'll say it again. The higher your TSH, the faster you walk. So there's no evidence that having mild subclinical hypothyroidism, if you're elderly, impairs your function in any way. And the important randomized controlled trial that was published in the New England Journal of Medicine in 2017, I think, really establishes the issues that are so difficult, because this randomized controlled, placebo-controlled trial of 737 adults over age 65 with subclinical hypothyroidism, half got levothyroxine, half got placebo, and after 1 year, there was really no difference in any of the outcomes, in hypothyroid symptoms, in tiredness, quality of life, etc. So in this study, the mean TSH was 6.4 and was 3.6 after they were treated with levothyroxine. In the placebo group, obviously it didn't change. And then again, as I said, there's no difference in any measure after 1 year of treatment. So no apparent benefits. And then there have been subsequent subgroup analyses from this study. So for example, that first one by Muyort, they looked at people over the age of 80 exclusively, no difference. This one by Montmolin, they looked at people with the most symptoms to start with, no difference. And then the last one from 2021, they looked at people with depressive symptoms only. And again, no improvement. And then finally, this issue, maybe they'll just continue to get worse and worse and worse, so we better intervene now. And from this study, the STOT study that I just showed you from New England Journal, this is an analysis was published last year looking at the placebo group. So these patients, obviously were not treated with levothyroxine, and this is looking at the probability of normalization of the TSH over the course of the year of the trial. And, amazingly, depending on what your TSH was at baseline, that's on the x-axis, you can see people with TSH levels of 5, 6, 7. There's at least a 50% chance that their TSH would just spontaneously normalize without any treatment whatsoever. And this was more common in younger people and people who had no antibodies, but certainly some of them who had antibodies also normalized their thyroid function. And so we have this idea that you're euthyroid, and then you become subclinically hypothyroid, and then over time, you just get worse and worse and worse, and finally you end up, with overt hypothyroidism. But the reality is that up to 50% of people become normal again without any treatment whatsoever. So we come to this cross in the road when we see a patient like I presented to you, to treat or not to treat. And the arguments in favor of treatment are that maybe there is an impact on morbidity and mortality as TSH gets higher and higher and higher, maybe related to dyslipidemia or atherosclerosis. Maybe there are effects on mood and cognition and symptoms. Remember, that study that was published in the New England Journal only looked at people over the age of 65. So it may be that in younger people, there's more of a case that could be made. And as I showed you in that other study from the UK Practitioner Index, it seemed like treatment may have benefited younger people. And then this idea that maybe you'd prevent progression to overt hypothyroidism. But on the other hand, in the elderly, there's really very little evidence that it would be a benefit. There's no evidence that it would improve symptoms or quality of life, especially, again, in the elderly. I told you that TSH often normalizes, and there's a cost to taking the medicine, and there's this danger that I told you about of over-treating people inadvertently. So this is from a review article published in JAMA a few years ago. This is just looking at patients less than 65. The TSH levels are all the way over on the left. So if the TSH is between 4.5 and 7, let's say, maybe you would measure antibodies. You would follow people, obviously. You would consider treatment in people that did have a lot of symptoms, or maybe people that had antibodies because they may be more likely to progress. Obviously, anybody who wanted to become pregnant would be treated. And then I think also people with goiters or thyroid nodules should be treated because the high TSH may be a stimulus for further growth. If the TSH is between 7 and 9.9, I think many of us would treat a younger person because of this possibility that it may reduce cardiovascular risk. And then 10 or greater is a line in the sand where everybody, I think, would treat this person. In people over the age of 65, it's hard to recommend treatment for TSH levels up to 7. But when the TSH is between 7 and 9.9, you might consider treatment. Maybe there is some benefit in terms of cardiovascular mortality. And then, as I said, greater than 10, we all would treat such a patient. So here's our patient. Should she be treated with levothyroxine? I would say not. Her TSH is around 6. She's 70 years old. There's really no benefit that we can find. That chronic fatigue that she has, remember, the trials show that this will probably not be benefited by treating her. And there's the danger of overtreating and giving her a subnormal TSH. So this is what I have talked about over the last 40 minutes or so. We talked about overt hypothyroidism, how to treat that. We touched on pregnancy. We spent a lot of time talking about subclinical hypothyroidism because this is 80% of all hypothyroidism. And I hope that you enjoyed the talk, and thank you very much for your attention.
Thank you, Professor. We now hand over to the Mumbai team for the panel discussion and the audience Q&A.
Thank you. Thank you, sir, for those crisp, clear, and very informative talk covering a spectrum of hypothyroid individuals. Thank you very much.
You're welcome.
I have a lot of questions, but I'll take a few of them.
Okay.
The first question is in regards to TSH estimation timings. Does the timing of blood collection matter?
No. There is a circadian rhythm to TSH. It is higher in the evening, so after 11 o'clock at night. In other words, if you admit someone to a research center and draw their blood once every hour for 24 hours, there is a rhythm, but it's highest at night. So it really doesn't change much during the day. So the answer would be no, it really doesn't matter.
Prandial, non-prandial does not matter.
No.
Okay. So there's another question in regards to interpretation of reports that they come across reports with normal T3, T4 with raised TSH and vice versa in regards to its interpretation.
Well, if the T4 and T3 are normal and the TSH is elevated, that is subclinical hypothyroidism. Now, if the patient is 80 years old and the TSH is 6, that could just be a normal TSH for that person. You might repeat the tests in a few months to see if it's stable. Sometimes the TSH can be transiently elevated because of mild thyroiditis, let's say. But there's no, so there are a couple of other reasons why the TSH could be high. One is severe obesity can make the TSH high. This has to do with leptin, which is secreted by fat cells that acts on the hypothalamus and pituitary to increase TRH and TSH secretion. And this resolves as soon as the person loses weight. So there can be sort of a falsely elevated TSH in extreme obesity. But generally speaking, if the TSH is high, it means they have mild hypothyroidism, or it's just normal for that person if they're elderly.
And vice versa? The second part of the question was vice versa.
What was what?
The second part of the question was if T3, T4 is high and the TSH is low. The other.
If the T4 and T3 are high and the TSH is low, then they're hyperthyroid.
Simple.
How about if the T4 and T3 are high and the TSH is high too.
So
What's that? So that is something that you should not ever see, right? So that could be a pituitary TSH secreting tumor,
or resistance.
or it could be
Resistance.
congenital thyroid hormone resistance, which does exist.
So I think this is an interesting question in regards to, since thyroxine has a half life which is pretty long, can't it be given once a week? Your thoughts on that?
Yeah, I mean, in certain circumstances where people are not able to take their medicine faithfully because of, let's say, cognitive difficulties or psychiatric problems, and they don't live in a facility where they can be given their medicine each and every day, a person, a relative, a family member could go and see them, or they could, just if they're living with a family member, they could be given their medicine 2 times a week, let's say, and that would be okay. I mean, it's not ideal, but it's better than not taking it at all. So yes, you could give a person all 7 tablets in one dose once a week. Yes, that could be done.
I had one question in regards to T3 dosing. One is in regards to its timing and in relation to its meal. Number 2, in T3 supplementation post thyroidectomy, total thyroidectomy, post malignancy, how do you dose it?
Well, as far as the absorption of T3 is concerned, we don't really know a lot about that. There haven't been a lot of studies on T3 absorption as opposed to T4 absorption. I think most people feel that it absorbed even better than T4 is. So it's probably better to, not take it with food, but it's probably okay to. So what I tell people patients is to take their first dose of T3 with their T4 in the morning, and then to take their second dose of T3 before dinner time. Remember, the half-life is a day for T3, so you have to take it twice a day. And then, what was your second? I can't remember the second part of your question.
In patients with malignancies post-surgery, when you're awaiting radioactive iodine ablations.
Yeah. So most people who have had their thyroid ablated from surgery or Graves' disease with radioiodine, they feel perfectly fine on T4 monotherapy. I mean, I've had Graves' disease, I've had radioiodine, I've been on T4 therapy for 50 years. And I take T4, and I feel fine. But again, it's not everybody that needs or should be even considered for T3 therapy. It's just the occasional person who, after a thyroidectomy, let's say, they were feeling perfectly fine before they had their thyroid out. Now they're on levothyroxine. Their TSH is 1, but yet they're still tired. They're still gaining weight. They don't feel the same as they did before their thyroidectomy. That is the patient where you might consider T3 therapy.
My question was in regards to post, suppose a patient has papillary thyroid cancer and has undergone thyroidectomy. Now, while you're awaiting radioiodine ablation.
Yeah, I mean, so if you want to prepare the patient for radioiodine therapy, yes, we do T3 for a few weeks while we're waiting for the T4 levels to decline, because its short half-life allows us to do that. I'm sorry, I didn't understand your question. But yeah, you could replace them with T3, let's say 10, 15 micrograms a day, something like that. In the United States, we don't usually withdraw people like that anymore. We use human recombinant TSH. So people stay on their levothyroxine and their TSH levels are high because of the exogenous TSH. I'm sorry.
Recombinant is pretty expensive over here, so it's almost $1 lakh.
Yeah.
So that's the reason why, in case.
Mm-hmm. Sure.
I think, do we have more time for the Mumbai team or? Okay. So there's a clinical case that a patient with first trimester with a TSH of 3.1 and antibody is negative. Would you treat or not treat?
No. That's a normal person. Yeah.
I think we've covered most of the questions.
Well, thank you very much.
So one question was, is there a ceiling to the dose of levothyroxine? What is the maximum dose?
It's funny. I got asked that yesterday too. And I don't know. I mean, in my, clinical career, I guess I've given people a high dose as 400 micrograms a day, something like that.
Okay, ma'am has a question that in severe hypothyroidism, first trimester, can the patient continue pregnancy if the TSH is more than 15?
Sure. So, yes, absolutely. I mean, the baby has its own thyroid after about 15 weeks of gestation. Now, the baby in the first trimester, some growth and development is dependent on the mother's thyroid hormone crossing the placenta. So you could argue that if the mother is severely hypothyroid, maybe the baby won't have enough thyroid hormone during the initial first trimester, but they can catch up. And I really don't think that having a high TSH like that would be a reason to terminate the pregnancy. I really don't. Because the baby ultimately will have its own thyroid.
Thank you very much. That's what it was from Mumbai team. Thank you, sir.
Thank you so much for your attention.
Thank you so much, Dr. Parmar. And we'll now move to Delhi and Dr. Saket Kant. Over to you, sir.
All right. Thank you very much, Dr. Cooper, for that very, very interesting talk and
Thank you.
enlightening talk.
My
We
pleasure.
have a few questions from Delhi. First is from Dr. Devesh that basically we're talking about the replacement dose of levothyroxine. It's around 1.6 microgram per kg. So would that be, the dose for all patients? For example, a post-surgical hypothyroidism in which the total gland has been removed, probably after radioactive iodine therapy also,
Yes.
versus a patient who's got early Hashimoto's, wherein some gland is functional. Probably the dose would be probably different in both of these, or you'll just start with 1.6 in a young patient.
No. So if a patient has has some intact thyroid function, you could give the person 1.6 micrograms per kilogram per day. That would just completely replace their thyroid function. So you could do that, or as many people do, you could say, well, let's say 50% of their thyroid is still there. You could give them just half as much that they might need, and that would also restore normal thyroid function. And then you'd have to monitor the person because periodically their thyroid would progressively fail, for example, and the dose may need to be increased. Yeah, I didn't mean to imply that everybody has to be treated with the full replacement dose if they haven't had a thyroidectomy. I mean, certainly you could start out with the lower dose and then progressively increase it if need be over time. Yeah.
The second question is that we see a lot of patients with CKD who would come to us with a thyroid profile. They will get a full thyroid profile, FT3, FT4, TSH they've got, are waiting for a renal transplant, for example. And the nephrologist would send the patient to us, whether the patient needs replacement or not. So would you be happy to, because a lot of things in CKD, for example, metabolic acidosis, malnutrition, inflammation, proteinuria are going to change the thyroid profile. So what would be your advice? How does CKD alter the thyroid profile, the thyroid function? And when would you like to treat a patient of even subclinical hypothyroidism when the patient has CKD?
Yeah, that's a great question. And there's not a lot of data on this. I just can tell you that it's my impression that chronic renal disease does not really change things very much. I mean, it may be that if patients have extreme proteinuria, maybe there's some thyroid hormone loss in the urine, but that would be more of a patient who's already on levothyroxine. So if someone is, let's say, on levothyroxine, they have nephrotic syndrome, you can lose a lot of thyroid hormone in the urine because it's bound to TBG. So the dose may need to be increased in people with nephrotic syndrome. But let's say a person is just on dialysis or they have chronic renal disease, things really don't change that much. So I think, yeah, you just do whatever you think would be appropriate for that patient.
So if you have a patient with CKD waiting for transplant, the T4 and T3 are in the lower quartiles, and your TSH is just about touching 9, because a lot of data from nephrologists would argue that if you treat this patient, you increase the renal blood flow. And probably the chances of rejection also decrease when you treat a patient such as in the lower quartile of T3, T4.
Mm-hmm.
What would be your opinion?
You know more about that than I do. Honestly, I can't even answer the question. Maybe the nephrologists are right. I mean, let's face it. We're not talking about starting some horrible drug that has lots of side effects. I mean, it's pretty innocuous. So if the nephrologist thinks it might help the patient, I would do it. It's not going to hurt the person.
Because sometimes their argument is they have seen patients of clinical hypothyroidism with proteinuria. If they get the TSH down, the T3, T4 in the higher quartiles, probably the proteinuria disappears.
I'm not aware that that is the case. But thank you for telling me about this, because now I will research this and yeah, if there are any references you have, you could send them to me. I'd like to read about that. I'm not aware of that.
So another question for Dr. Praveen. Your focus in the presentation was only TSH, but probably because in our country, all our patients would get back to us probably with the FT3, FT4 TSH all the time. So do you think it's only a TSH that is important, or a full profile may help more deciding the therapy, and probably with the clinical features like heart rate, weight loss, anything like that, with a full profile would be more beneficial as compared to TSH? The second part of the question is, if you have a patient with normal TSH, but the T4 is high on levothyroxine therapy, would you like to alter the dose or you'll keep the dose same?
Okay, to answer the first question, as much as I hate to say this, I think getting the TSH only is adequate. And I think it is much more cost effective. It doesn't really matter what the T4 and T3 are. If we're using the TSH and the pituitary gland as our judge of what is normal for that person, and granted, maybe that's not valid, but if we're using the TSH as the judge, it doesn't really matter what the T4 and T3 are. I mean, you could say, well, gee, maybe the T3 is on the low side. That might justify giving T3 therapy plus T4 maybe, but I don't think it matters. And in terms of the high free T4 and a normal TSH in someone taking levothyroxine, we see this a lot. And it's hard to explain, but I would not decrease the dose just because the free T4 is high if the TSH is normal. There may be, as you get more and more T4 in your body, the conversion of T4 to T3 actually goes down. And that can lead to the T4 being on the high side or even above normal, even though in that same person, I guarantee it, the T3 will be on the low side.
All right, so a question from my side. Do you think you can expand the indications of T3 to, for example, a patient with hypothyroid coma in which you want early recovery, you want to make the patient better, in which hypothyroid coma would have decreased T4 to T3 conversion. So probably T3 would be an indication in hypothyroid coma. Probably a patient taking steroids, again, T4 to T3 conversion goes down. A patient with sick thyroid syndrome, inflammation and interleukins decreasing T4 to T3 conversion. A patient with central hypothyroidism, because we know that TSH increases conversion of T4 to T3. So a patient with central hypothyroidism will do better on T3 versus T4?
So just one last point. TSH doesn't increase T4 to T3 conversion. I don't know. That's not the case. But for all those other reasons you were talking about, yes, this is really important. And, there are no randomized controlled trials comparing levothyroxine alone versus levothyroxine plus T3 in mixed edema coma. Some advocates recommend starting T3 and T4 therapy at the same time in people that are, critically ill with severe hypothyroidism. Other people think it's better just to give T4 alone, and then if there's no clinical improvement, add T3 in a few days. The reason people shy away from T3 in illness and starvation is because this is the body's defense mechanism. In other words, why is the T3 low if someone is sick? It's because you don't want a lot of T3, because T3 is a metabolically active hormone that just increases your metabolism. So the body, in its wisdom, is doing this. So the idea of saying, oh, the person, is critically ill, let's give them some T3, that's not necessarily the right thing to do, except in critically ill mixed edema coma. Yes, that would be reasonable. But let's say a person is in the hospital with heart failure, pneumonia, renal failure, and their T3 is low. That would not be a reason to give them T3. It just might make them worse.
The last question from the Delhi team. Dr. Shashank has a question that there are some papers that suggest maintaining T4 to T3 ratio of 6:1 when combining T3 to LT4. But because measurement of T3 is difficult, short half-life, are there any practical or clinical parameters like heart failure that can help you decide the dose of T3?
That's why I said there are all these recommendations, but the easiest thing to do is just assume that 5 micrograms of T3 is approximately equal to approximately 20 micrograms of T4, 15 to 20 micrograms, and then just substitute that amount of T4 with T3. I don't know. There are other ratios of, molar ratios and the secretion rates and that sort of thing, but it's just too complicated. So no, I don't have any other advice. Yeah.
All right. Thank you very much. That's all from the
Thank
Delhi team.
you. Thank you so much for your attention. Enjoy your evening.
Thank you, Dr. Saket Kant, for taking it from Delhi. Now we come to Bengaluru, and Dr. Vagesh Iyer is ready with his question. Over to you, sir.
Okay, it's a pleasure listening to you,
Thank you.
Professor Cooper. I think we have got a lot of questions, some of them being covered by Mumbai and Delhi team. So
course.
whichever not been covered, I'll be asking. Is it still practiced a full starting dose of L-thyroxine or a stepwise increase on which clinical situation?
Yeah, I think that in younger, otherwise healthy people, it is perfectly fine to start on a full replacement dose. I can't tell you how many people I see who are, 20 or 30 years old, and their doctor has started them on 25 micrograms of levothyroxine a day when their TSH was 60. And now they're seeing me a few weeks later and their TSH is 40 and they're not feeling any better. There's no reason to start low and go slow in a healthy person. Only in an older person or someone with cardiovascular disease would you have to worry about that.
Is there any cutoff for a TSH or a total T4 in surgical fitness patient? You know that if person is called for a surgery and TSH is high, you need to wait for 4 weeks or 6 weeks. Is there any cutoff where we can give a surgical clearance?
That's a great question. All I can say is there are studies of people that have gone to surgery before they had thyroid tests, and then they came back, and it turned out the person was hypothyroid, and nobody knew it, but they went to surgery anyway, and the outcomes are really not that different from euthyroid people. So I would say that if the surgery really needs to be done, and the person, was basically feeling okay, and they weren't profoundly hypothyroid, it would be fine. But if you want a cutoff, I guess I would say if the TSH is less than 20, it would be okay for them to have surgery.
I think that's a great answer. That's how much weight loss we can expect in somebody who's obese hypothyroid?
Somebody who
is obese and overt hypothyroid. Weight loss, how much percentage of weight loss we can expect with L-thyroxine therapy? That's
0. Well, no, I'm kidding. I mean, this idea that hypothyroidism causes obesity is just not right. It's possible that a person might gain, 5 or 10 pounds if they become hypothyroid, and so that would be expected to change. But the person is not going to lose a tremendous amount of weight if they are markedly overweight.
Do we have anything known as a L-thyroxine enhancers, absorption enhancers?
That's a great question. No, I don't know of any. I wish there were, but no.
And which are the clinical situation where we can just ignore mild increase in TSH?
Those are all the clinical situations. In other words, if a person has a TSH of 5 or 6 and they're feeling okay, I wouldn't treat that. The only exception I would make would be a child or a pediatric age group. I think those people should be treated just because we don't know what the outcome would be in a kid who is in school, and maybe it would improve their performance or their health in some way. But for an adult who has a TSH that's slightly elevated and they're feeling okay, I would not do anything to treat that except to monitor their TSH. Again, the other exception would be if they have a goiter or if they've had thyroid nodules. There are data to show that thyroid cancer is more prevalent in people who have Hashimoto's thyroiditis, and the prevalence of thyroid cancer is linearly related to their TSH, even within the normal range. So I would, if before I decided not to do anything, I might get an ultrasound and see if there are nodules in the thyroid, and if there were, even if the person was feeling okay, I probably would treat them.
How fast we should bring down the TSH in a pregnancy? What's the timeline? Somebody with overt hypothyroidism, how fast we should bring down?
As soon as possible. I mean, you want to correct this as quickly as you can. I mean, there's a higher rate of miscarriage, mainly, in people that are hypothyroid. So I think if the person is profoundly hypothyroid, let's say the TSH is 30 or 40 or 60, whatever it may be, you want to start off with the full replacement dose plus extra because they're pregnant. Remember, in pregnancy, the dose goes up by 15 or 20%. So you might calculate what their full replacement dose is and add to that even.
I think major food restrictions in a patient with hypothyroid.
Zero.
Yeah.
I'm not aware of any. I mean, there are, so certain people think that large amounts of soy may impair the absorption of levothyroxine, but no, there shouldn't be any food restrictions.
Yeah, I think there is one more last question. Is iodinization is a boon or a bane for a thyroid?
Iodine?
Iodinization, is it a boon or a bane for a thyroid?
It's a boon.
Okay, fine.
Who would be asking that?
Yeah,
How could it be a bane?
yeah.
I
The only
mean-
thing they are telling this because of iodine, we are seeing more and more of a hypothyroid autoimmunity. That's
Yeah. Well, but you need to have iodine in your diet for your brain to develop normally. So I think we'll take that as a side effect, maybe. Yeah.
okay. Thank you.
so much. Okay. Take care.
Thank you so much, Dr. Iyer. Again, I'm really some very exciting questions, Dr. Cooper. And now we move on to Hyderabad Center. Dr. Beatrice Annie is there. She's ready with her questions.
So greetings from Hyderabad.
Good
Thank
evening.
you, Dr. Cooper. It was an absolute pleasure listening to you.
Thank
so,
you.
Since we are the last to go, we don't have too many questions.
Okay, that's fine.
Start with one of the common questions, in fact. What would be your recommendation regarding the timing of thyroxine dose during periods of religious fast, like during the holy month of Ramadan?
Mm-hmm. It really doesn't matter when a person takes their medicine since the half-life is so long. So if a person typically takes it in the morning, but then they're fasting and they can take something after sundown, let's say, they can just take it then. It doesn't matter that much. Just as long as they take their medicine every day. It really doesn't matter what time of day it is taken.
You had mentioned in your lecture about bedtime dosing of thyroxine. So
Yes.
what would be the recommendation regarding the time gap between dinner and the thyroxine dose?
Right. So patients always ask this as well. I mean, if they have dinner, let's say at 6 or 7 o'clock at night, and they go to sleep at 10 o'clock, there's this. And as I said, there have been studies looking at how long it takes for the stomach to empty after you have a meal. And a typical patient or typical human being, the stomach is emptied after about 2 hours. So as long as there's a 2-hour gap between the last meal and bedtime, that should be okay. And a lot of people, I'm sure you have patients like this too, where people sometimes set their alarm for 5 o'clock in the morning just so they can take their medicine, and then they go back to sleep even, so they don't have to interrupt their breakfast or whatever. And I just think that's really it's a little crazy. And so for those kinds of people, I think it's fine to take it at bedtime.
About 2 hours after dinner is what you would recommend.
Yes.
You also mentioned about seasonal variation in TSH levels. So would you recommend a change in dosing of levothyroxine during winter?
I didn't really mention that. That was on my slide. So there are studies from Japan mainly just looking at seasonal variability in TSH levels. And it's interesting that in the wintertime, TSH levels are higher than they are in the summertime. You might even think that maybe the body is trying to generate more thyroid hormone to make people warmer in the winter and maybe cooler in the summer. But that's not a factor that would go into changing the dose of medication or treating a person or anything. It's just kind of an interesting physiological fact.
So when would you recommend getting an anti-TPO antibody done other than subclinical hypothyroidism?
Never. I mean, if a person's hypothyroid, it doesn't really matter if they have antibodies or not. But if they're subclinically hypothyroid and they have positive antibodies, that might make you think, oh, maybe this is patients more likely to progress to overt hypothyroidism. That might be a reason to consider treatment. But if the person already is hypothyroid, let's say with a TSH, that's high and their T4 is low, it's almost always, it's Hashimoto's. There's no other diagnosis. Assuming they haven't had a thyroidectomy or something. If it's spontaneous, then it's always Hashimoto's.
Your thoughts on role of selenium in thyroid disorders, would you recommend selenium supplementation in any of the thyroid disorders?
That is a great question. And I don't have a great answer. So, as many of you know, selenium has been used in various autoimmune diseases. Why it seems to be effective in some cases, I don't know. The problem is, at least for me, is that most of the studies that have shown that selenium may benefit people with autoimmune disease in terms of lowering their antibodies, or people with thyroid eye disease, where there's some evidence that it may help thyroid eye disease and Graves' disease. The problem is, in the United States, we don't have selenium deficiency. And most of the studies that have been done have come from Europe, where there is selenium deficiency in the general population in the diet. So that might be the reason why it works in some parts of the world and maybe not so much in other parts of the world. And I don't know what selenium intake is in India, for example. I bet this has been studied. There are people that, study this. So that might be interesting, but it's pretty harmless. So if a person wants to try taking selenium to see if that has an effect on, let's say, their antibody titers, that would be fine. I don't think, let's say a person has hypothyroidism and their TPO antibodies are 100. And now they take selenium and now their TPO antibodies are 50. I don't think that's really had any impact on their underlying thyroid problem, really, in terms of whether they need to be on medicine or not. There aren't any data to show that people can go from needing levothyroxine to not needing it just because they took selenium.
One last question. Is there any data to show any effect of hypothyroidism on cognitive behavior and memory in young patients?
I don't know of any, but I can't imagine that there would not be. I mean, any effect that it would have on older people, I can't imagine why it wouldn't have an effect on younger people too. But I don't know, I'm not a pediatric endocrinologist. I don't know the data on this. I will say that, at least in my experience, many pediatricians, when they find mild hypothyroidism in a child or teenager, they don't treat it. They think, oh, this is just going to go away as the person gets older. I don't understand that rationale. If a person, let's say a 12-year-old, has a TSH of 10, I don't know why you wouldn't treat that person. But again, some pediatricians think it's not necessary. I personally would treat that person. When I say pediatricians, I mean pediatric endocrinologists in the United States. Yeah.
Thank you, Dr. Cooper. That's it from our side. Thank you for
Okay.
sharing your thoughts with us. Thank you.
Thank you, Dr. Anna. Thanks again for your attention.
So I would pass it again to Mumbai, to Mr. Abhijit Ganguly to tell the final vote of thanks.
So good morning, Dr. Cooper, once again, and thank you. Thanks a lot. And good evening, everyone, the guests across India. And this is the second day for people who have joined us today. This is the second day which we are hosting Dr. Cooper. And he has been fantastic for both the days, has really followed each and every question, has answered each and every question and made it so simple for all of us. Thank you, heartfelt thanks to you, sir, and for really making thyroid disorders and especially hypothyroidism so simple for all of us. Almost 900 doctors have got educated on hypothyroidism from you, sir. Thank you so once again. And thank you at the other venues for the other doctors who have joined us for the evening, especially Dr. Girish Parmar over here. We have Dr. Saket Kant at Delhi. We have Professor Dr. Vagesh here in Bangalore. We have Dr. Beatrice Annie at Hyderabad. So please, once again, thank you and for hosting the session, and for other doctors who have joined us for the evening. Have a great evening, and please definitely remember Thyrox is definitely with you as a brand. We are available in 12 different strengths, and it's the only brand in India which is made right from the raw material till finished formulation at McLeod's own factory in our own US FDA plant, which is quite different than the other brands which are there. Thank you once again. Have a great evening, sir. Thank you, sir.
Bye.
So thank you to all, and thank you, Professor Dr. Vagesh Iyer, for taking the questions. We have the privilege of Dr. Vagesh Iyer being here, and probably if some of the questions were not answered, or there are still some, very practical clinical cases where you would like to have a guidance, I would invite you to please ask Dr. Vagesh Iyer. We have mics here; we can roll it across to the audience. Maximum covered. Okay. Any final takeaway messages, sir? For
Recording stopped.